Namaste and good afternoon, everyone. I hope you enjoyed the lunch and are ready for an engaging afternoon. I am Dr. Prasansa Sake
And I am Dr. Sanket Parazuli.
and we will moderate the rest of the session.
Our post-launch session is packed with insightful presentations from experts all over Nepal. We will be exploring various subspecialties, and I am excited about the valuable insights our speakers will be sharing. So without further ado, let's start things off with our first speaker of the session, Professor Dr. Sanjay Singh. He is the founding medical director of Viratnagar Eye Hospital and has served as the program director of Eastern Regional Eye Care Program. He has received several awards, including the Antonio Champellimot Vision Award in 2013. He has served as the president of Nepalese Ophthalmic Society in 2014 and is currently the medical director of Siddhartha Eye Care. He will be presenting on the topic management of bullous keratopathy. Welcome, sir.
Yeah, I know the slide. Thank you very much for the kind invitation and the very warm hospitality. And it was very good to know that this hospital has performed the first keratoplasty, and that too was on the bullous keratopathy. And I hope they will be doing many more in the future. So bullous keratopathy is not a very uncommon thing. It is quite a common thing, and it happens mainly after the cataract surgery in our setup. So I will be sharing my experiences with the bullous keratopathy. So I will just begin with a case study. This was a case like the 45 years old male. He was operated somewhere in India with the phaco with foldable intraocular lens implantation about 4 years ago. And after the surgery, he had constant redness, foreign body sensation, and pain in the CMI. And he had visited 51 eye hospitals and eye clinics without any improvement in symptoms. And his vision was very blurred. He had the hand movement vision, but the good thing was he had the accurate projection of rays in all the directions. So he had conjunctival congestion, and the cornea was quite hazy. It was mainly edematous in the center. The scarring associated anterior details were very hazily visible, but we could see the reflection of the intraocular lens. So based on this finding, for me this was a case of the pseudophakic bullous keratopathy, whereas previously in all those eye hospitals and eye clinics, he was being managed as a case of the viral keratitis. They thought that this is a case of the interstitial keratitis, and they were managing on that line. And the B-scan ultrasonography was within normal limit. And when I told the patient, okay, you have to undergo the surgery, so he was telling that, oh, I won't go the surgery because I am the case of the viral keratitis. But finally, he agreed for the surgery. And this is the surgery we performed, and this is the picture on the very first post-operative day. We can see that the graft is very nicely placed. It is well attached. Anterior chamber is nearly 2/3 filled with the air bubble. Inferior PI is patent. And this is the slit lamp view. And this is the picture after 1 month. Gradually the redness is decreasing. The cornea is gradually clearing up. And the central part of the cornea, it is not edematous anymore. So before, the patient had the hand movement and he was quite symptomatic. This was the picture. And just within 10 weeks, his vision had improved to the 6/18, and he was totally asymptomatic, and he was doing very well. So the moral of the story is that many times after the cataract surgery, the patients, if they have the persistent corneal edema, then we should not always think that this is the case of the viral keratitis. We have to keep in mind the first thing could be the bullous keratopathy or the pseudophakic corneal edema. So what is the mechanism? Actually, the whole mechanism is that the endothelial cell layer, it fails to function. There is stromal swelling, and because of the stromal swelling, the visual acuity is compromised. He is having the tearing, hazy vision, and the photophobia. And there is subepithelial filled bulli are there, and if they rupture, then they lead to a lot of pain. And this whole condition is known as the bullous keratopathy. So these are the main signs and symptoms that we have already discussed. So what are the causes for this pseudophakic corneal edema. There could be direct trauma during the surgery, either with the lens particle when we are doing the surgery. If we are not doing the surgery at the iris plane or in the capsular bag, and if you are doing the surgery mainly in the entry chamber, then there are more chances that we may be damaging our endothelial cells. So there could be some toxic medications that can lead to this trauma to the endothelium. Prolonged irrigation, suppose whenever we are removing this epinucleus and the cortex, and if you are doing a lot of irrigation and aspiration, so those things also can damage the endothelium. If there is prolonged inflammation, and if you are unable to control the inflammation, that could be also damaging. Increased intraocular pressure, so we have to control the intraocular pressure in the post-operative period very well. And many studies they have suggested, suppose if you are putting the entry chamber intraocular lens, then gradually there is compromise in the endothelium cells. So what happens in the mild to moderate edema? Usually there is epithelial bullies are there. There is separation of the stromal, separation of the lamellae, and there is the Descemet's membrane thickening. But when this is the chronic edema is there for the longer duration, usually we get the subepithelial fibrosis is there. So our main intention is we should not try to go into this phase. Before that, we have to manage this. So treatment options, there are various treatment options are available. One is the medical management. We have to give the topical hypertonic saline, that is the 5% sodium chloride solution. We can give it 4 to 6 times a day. Then the hypertonic eye ointment, this sodium chloride eye ointment is also available. This is the 6% is there, so we can apply it at night time. We have to control the inflammation with the anti-inflammatory drugs. We have to control the intraocular pressure with the anti-glaucoma drugs. And we have to give a lot of lubricants to the patient for the symptomatic relief. Bandage contact lens is also very useful, especially to relieve the symptoms. Corneal cross-linking also has got some role. It causes the temporary reduction in the corneal edema, and it improves the corneal transparency also. It induces the stromal compaction, but the main problem is that it does not have the long-lasting effect. So it is not the permanent solution. This is my personal algorithm for the management of the pseudophakic bullous keratopathy. So whenever I get a case of the pseudophakic bullous keratopathy or the bullous keratopathy, I usually try to find out like what is the visual potential in these patients, whether there is a potential for the good visual outcome or whether the patients doesn't have the potential for the good visual outcome. Suppose if there is the poor visual outcome is expected, then usually I do not try to convince the patients for the keratoplasty. And at the time, I try to do some procedures that is for the symptomatic relief. So there are some procedures that can lead to the symptomatic relief in the patients. These are like the conjunctival flap, that we also tell that this is a Gunderson flap. The stromal puncture also functions quite well. We can do the amniotic membrane graft, and we can combine both the procedures, amniotic membrane graft as well as the stromal puncture. We can combine it as the package procedure. For patients who have the good visual outcome, so my procedures are the penetrating keratoplasty or the DSEC surgery or the DMEC surgery. So this is the case where the Gunderson flap was done. This is quite effective in reducing the symptoms, but the outcome is not very good. The patient eye doesn't look very good. And as a corneal surgeon, I do not like this procedure because I want to keep my cornea very clear. I do not want to have the blood vessels, because suppose if I try keratoplasty in this patient, there are more chances of failure in these cases. So I usually try to avoid the Gunderson flap, and I think in last 10 years I haven't done any Gunderson flap. So that was the procedure that I had done before 10 years. So anti-stromal puncture, this is the procedure that can be done in the OPD under the slit lamp, and this functions very well. It increases the expression of the extracellular matrix proteins, and that increases the adhesion of the epithelium to the stroma, and this creates a kind of the barrier for the liquid to come to the subepithelial space. So this is also quite a good procedure, can be done in the OPD, but the main problem is again the patient will come with these kind of symptoms. This amniotic membrane graft, like this is one of the patient, he had this bullous keratopathy. If you look into the cornea is quite edematous. So this patient underwent amniotic membrane graft. This is the picture on the very first day, and this is the picture in 1 month. The cornea is gradually clearing up. Of course, I do not expect the very good vision in these patients, but usually they are symptomatically they are doing very good. And this is the picture after 2 months. Keratoplasty, there are several procedures. The penetrating keratoplasty, DSEC that I showed in my first case presentation, and there is DMEC procedure also. So this is the case, actually this is a very interesting case. Yes, this case had undergone therapeutic keratoplasty in Disha Eye Hospital, and he had quite a good vision after some time. But what happened, like later on his vision decreased, and cornea was a little bit edematous. Of course, when we see into this picture, like the cornea is quite okay, but cornea was edematous and his vision was compromised. To me, it appeared as a case of the bullous keratopathy, so I planned to go ahead with the DMEC surgery. And here I am removing the Descemet's membrane. And once I have removed the Descemet's membrane, we are injecting this Descemet's membrane, and we have to always stain it with the trypan blue, because our iris is quite brown, so we need a kind of the contrast. So once I have implanted this Descemet's membrane, then I have to unroll the tissues. So here with the 2 cannula method, I am trying to unroll the tissues, and this procedure is quite challenging because you cannot touch the cornea. You don't have the liberty that you can touch this Descemet's membrane by going into the antechamber. So we have to do just the indirect manipulation from over the cornea. So the cornea is almost, I have done the unrolling of the cornea, and then after I have to go beneath the Descemet's membrane and in front of the iris tissues and just inject the air bubble, and the graft is in place. And this patient did very well in the post-operative period, and he came up with the 6/9 vision. So all these procedures are quite effective, and being in Nepal, we have to develop our algorithm for the management of the bullous keratopathy. So it is always good to have a look whether the patients are going to benefit with the surgery or not, and what is their visual outcome. If their visual outcome is always poor, then please think of other procedures other than the keratoplasty, because we have the shortage of keratoplasty in the country, corneal tissues in the country. So we have to manage that very well. And if the patients, they have the good visual potential, then the first procedure of choice for me should be the DMEC, because that is quite a challenging procedure, but the visual outcome is quite excellent. Next procedure, I would like to have the DSEC, and in some cases, penetrating keratoplasty. So thank you very much for your kind attention.
Thank you, Professor Dr. Sanjay Kumar Singh. Since he has to go take an early flight, we would like to express our appreciation promptly. I kindly ask Professor Dr. Anand Kumar Sharma to present the award to Professor Dr. Sanjay Kumar Singh.
Now let's move on to our next speaker, Professor Dr. Rohit Saiju, who will enlighten us on the topic ophthalmologists for thyroid eye disease. Professor Saiju is an accomplished ophthalmic surgeon with nearly 2 decades of experience. He specializes in cataract and oculoplastic surgery and has received awards such as the APAO Distinguished Service Award and the SAO Excellence Service Award. Dr. Saizu is the immediate past president of the Nepal Ophthalmic Society and has played a vital role in establishing and expanding oculoplasty services nationally and internationally. Welcome, sir.
Thank you, Dr. Prasamsa, for a nice introduction. And thank you for the organizing committee, especially Dr. Ruchi Shrestha and the young lady ophthalmologist team. What I'm seeing here are organizing fantastic Reukai conference in this beautiful city of Dhulikhel. And this is very good privilege to me be here and share with you my experience in thyroid eye disease. You all know that thyroid eye disease is one of the very common diseases in the ophthalmology, and where the endocrinologist along with the ophthalmologists are the key player to give optimal treatment and management to our thyroid eye disease patient. I do not have any financial disclosure to claim here. Here we know Bob Graves in 1833 described the first disease of thyroid eye disease, and there is so many names given for the same entities like the bone basidos, which is a little bit earlier described, but in literature, Graves is come in the prominent. As other terminology given for the same disease is thyroid-associated orbitopathy, thyroid-related orbitopathy, thyrotoxic exophthalmos, this thyroid ophthalmopathy, thyroid eye disease, and thyroid orbitopathy. Among these, Graves' orbitopathy and thyroid eye disease is most commonly practiced terminology in the clinics. Here are our patients presented to us with different presentation with this disease. Like you see here, the lead retraction, one of the very common and initial presentation, then the exophthalmos, and then the restrictive myopathy, optic neuritis. I mean, basically we call the compressive optic neuropathy, and the inflammatory process around the orbit and eyelid. So thyroid eye disease, as a definition, it is a complex autoimmune multi-system disease where eye and around the eye orbital tissue are involved. There is no definite laboratory test can give you the definite diagnosis. Basically, this is the diagnosis of clinical manifestation. Look at this picture here. About 90% of thyroid eye disease patients are associated with the hypothyroidism, and the residual 10% are associated with the euthyroid or hypothyroid status. In the other way, the hypothyroid patients can convert into thyroid eye disease in about 25 to 35%, and they are prominent with the clinical manifestation or presentation, and other 65 to 75% of the subclinical hyperthyroidism patients can be turned to the prominent clinical thyroid eye disease within the period of the 18 to 24 months. It is said like that, but it is not always like all the patients will convert to the manifest of the thyroid eye disease, but there is a high chances to get into turn. The classical presentation, as I have shown in the picture here, the important graft, this is the Rundle curve. The modified Rundle curve consists of the two phases. The initial one is the active inflammatory phase, prolonged for the 6 months to 18 months, where the inflammation and the active part of the disease is occur, and that will be flattening with the unstable and the non-inflammatory stage. The role of management in the Rundle curve is that we hit the medical management to reduce or to suppress the inflammation and bring the severity of the inflammation in low, and then they convert to the stable and non-inflammatory stage of the disease, where we can go for the various reconstructive surgery to get the rehabilitation for social and cosmetic. The management and the evaluation of the disease is our job. So this is the multidisciplinary job where, along with the ophthalmologists, with internists, endocrinologists are involved in the management and the even the diagnosis of the disease. Internists and endocrinologists has a role to control the thyroid status, to bring the hypothyroidism condition to the euthyroid conditions. Whereas ophthalmologist, even specializedly you call that orbital surgeon or oculoplastic surgeon, neuro-ophthalmologist, and strabismus specialist, they will bring the patient to the normalized states of the ocular and periocular tissues. There should be a very good vicious circle between the endocrinologist and ophthalmologist, because we know that all the thyroid patients come to the endocrinologist first. They don't come to the ophthalmologist, as they know that when they suspect their patient to the thyroid ophthalmology or ophthalmopathy is going on in their patients, they should refer at the time. They shouldn't hold their patient with them till that the management will be difficult to get the things done properly. So once we get referred patient from the endocrinologist, we as an ophthalmologist are the key manager, key player to get the proper diagnosis and the management of the disease. And we will take care of the moderate to severe, even the sight-threatening condition of this disease. Thyroid eye disease is the whole ophthalmology, actually. If you see here, the lead retraction will cause the lag of thalamus, where the exposure keratopathy may result to the corneal ulcer and corneal perforation. So corneal people are involved in here to protect the cornea as well as the vision. And lead retraction along with the exophthalmos and periorbital swellings, these are the conditions dealt by oculoplastic surgeon. In the same way, the compressive optic neuropathy due to the pressure over the apical portion of the orbit, here the neuro-ophthalmologists are involved. At the same time, restrictive myopathy, this is another complication of the thyroid eye disease, is dealt by the strabismus specialist. So in looking at the clinical manifestation, the thyroid eye disease is the disease of the whole ophthalmology. So what is the aim of the treatment? So first, our aim to control the thyroid status of the disease. Then we should diminish or reduce or control the inflammatory stress and bring the stage of the disease in the non-inflammatory or stable conditions, and correction of all the sequelae of the inflammation in the lead as well as in the periocular tissue by different rehabilitation surgeries. The treatment portion will, enroll that there is social and emotional rehabilitation should be with our management things. In the medical management, which is applied during the active phase or during the inflammatory stage with the help of immunosuppressant, corticosteroids, and radiation therapy is applied to reduce or to control the inflammation of the disease. And once the inflammation is controlled, then the sequelae of the surgical procedure is involved here, starting from the orbital surgery, which is mostly the orbital decompression to expand the orbital volume, where the inflamed or swollen extraocular muscle can be accommodated within the orbit. In the same time, after the orbit has addressed their problem, strabismus surgery is involved, and then the lid surgery in the last. Being the ophthalmologist, look at this disaster and a very sad patient. This is our own patient. Initially, he came with just the exposure keratopathy, with little bit photophobia and diminished vision, and didn't take care properly. And because of the lack of thalamus and improper closure of the eyelid, then the corneal ulcer with the perforation occur. This can be simply protected by doing the tarsorrhaphy. With the lateral two-thirds of the simple sutural tarsorrhaphy can protect the cornea very well, and the middle one-third of the open part of the tarsorrhaphy is used for the installation of the drops. So diagnosis of the thyroid eye disease is basically the clinical, but still there are some criteria as given to put the diagnosis. The first is the status of the thyroid function. And thyroid function, one of them are two of following three signs should be there. And then the typical ocular sign, one or more of the following typical signs should be there. The signs already have shown there: the lid retraction, proptosis, restrictive strabismus, compressive neuropathy, or periocular edema. And the third one is the radioimaging. In radioimaging, even in CT or MRI, you should have one of the extraocular muscle is involved. The most common one is the inferior rectus, and followed by middle rectus, superior rectus, and lateral rectus is usually don't involve. If you see the lateral rectus alone is involved, it is not likely thyroid eye disease, it is something else. So clinical activity score of the disease is better to know, but due to the time, I will not discuss here. In the medical management of the thyroid disease, in the mild conditions, we have to control the thyroid function, cease the smoking, as the smoking is one of the provocating factor for progression of the disease, frequent lubricant to protect the cornea and conjunctiva, instillation of topical anti-inflammatory agents can make the suit to the patient, ask the patient to use the head elevation during the sleep, that will make less edema in the face in the morning, eyelid taping to protect the cornea after putting the ointment, and oral selenium has proved a role as it will slow down the progress of the disease, and at the same time it will increase the quality of the life of your patient. Intravenous, in the severe to moderate to severe conditions of your patients, then the steroid is a drug of choice, where according to UGOGO protocol, 500 mg methylprednisolone is given weekly for 6 weeks, then subsequently another 6 weeks with 250 milligram, in total of cumulative dose of 4.5 gram. And at this time, if the result it is not satisfactory, the inflammation is not controlled well as you desired, you can consider the external beam radiotherapy, the cumulative dose of 200 rats in the 10 fraction. In case of the optic neuropathy, compulsive optic neuropathy, you can continue the same UGOGO protocol as given above, or another protocol is saying that the subsequent 3 days with the 500 daily IV methylprednisolone, and then 500 weekly for 6 doses altogether. And if your medical management is not working, and your vision is threatening with the disease, then the prompt orbital decompression is required. Though surgical treatment is indicated once the stabilization of the acute disease, but when the vision is threatening, then we don't wait for the medical management, we can go for the surgical decompression process. For the prolonged condition of the inflammation, where the your methylprednisolone shots are not working, then you have to combine with other immunosuppressant drugs. The most common drugs are used in practice are the azothioprine 500 mg twice a day for 6 months, or mycophenolate mofetil 500 mg twice a day for at least for 6 months. And this is always combined with the low dose of the oral steroid. I have many cases where the IV methylprednisolone didn't work properly, and the inflammatory stage of the disease is still persistent. And combined with this azathioprine, the mycophenolate mofetil is very good. Both of them are equally good. It depends on the prefer of the surgeon. But I prefer azathioprine is a first. If it doesn't work, then go to the mycophenolate. Now come to the surgical management. As the fat decompression, which was described by Oliveri in 1984, being popularized, it has replaced the bony wall decompression in the thyroid eye disease. And the fat decompression as counted as a first wall decompression in the thyroid. Many surgeons remove the intracorneal fat removal as a first wall, where the exophthalmos of about 2 to 3 millimeter is improved with this fat decompression. I have a short video here. I don't know it is working or not. Okay, here Oliveri introduced in the cadaver orbit about 4 cc of liquid paraffin, and it produced about 6 millimeter of exophthalmos. So he has proven that the orbital volume increment or decrement can directly proportional to corresponding to the amount of the exophthalmos. That's why when you take the soft tissue from the orbit, then the exophthalmos is reduced proportionally. It is said that about 3 or 4 millimeter, 4 cc of the orbital tissue is removed, then you will have improvement in the exophthalmos of about 3 to 4 millimeter. Here in the orbit, it is about the volume of 28 cc, about 1 ounce, and eyeball occupied about 7 cc, and orbital tissue, especially not orbital tissue, I'm saying the orbital fat will occupied about 8 cc of the orbital volume, and rest of the volume occupied by the muscles, nerves, lacrimal gland, and etc. So when you remove the orbital tissue, orbital fat basically, I'm saying here, in the superior you say that there is a medial, central, and laterally there is no orbital fat because it is replaced by the lacrimal gland, and inferiorly there is a medial, central, and lateral as well. When you remove the inferolateral orbital fat, that will remarkably reduce the amount of exophthalmos. It is said that about 40% of exophthalmos is reduced with the inferolateral. As the volume, the amount of the this inferolateral orbital fat is enlarged, and it is connected with the intraconal fat pad. In the same way, inferomedial fat reduction will correct about 20% of the exophthalmos, and the central fat pad of superior and inferior orbit is usually not entertained here because it doesn't make much difference in the exophthalmos. And at the same time, when you remove this fat, there will be hollowness appearance will be there, and we don't want patient to make the hollow eye socket. In the same way, the superomedial fat pad, which is white in the color, also reduce about the 20% of the exophthalmos. So altogether, superomedial, inferomedial, and inferolateral fat pads are the main tissue to be removed. Okay, here I'm showing one of my patients presented with lid retraction and exophthalmos of about 3 millimeter in difference with the left eye. Here the lid crease incision is given, and you see the graded blepharotomy has done with the hinge of central conjunctiva to maintain the contour of the eyelid, and then it is closed properly. In the lower eyelid retraction, after the lid retraction, the fornix approach to the inferior fat pads. After incising the orbital septum, you expose the fat pad. The lateral and medial fat pad, you expose well and bring out, and you do twice cautery and then cut, because I always do the twice cautery to ensure that 100% hemostasis is secure, because you know that if hemostasis cannot secure, the vessel in the fat pads, they can retract easily and difficult to find out, and can give easily the retrovalvular hematoma, which is another vulnerable condition to produce the compressive optic neuropathy. So cauterize the fat pad and then make a good incision, and then put couple of suture in the conjunctiva, and then put the eye pad. You see, this is immediately after the surgery in the operation theater bed. So here's the same patient before the surgery here, and the right hand side, the incision. I remove about 3.5 cc of the fat from the right orbit, and which improve lid retraction. Lid retraction improved by the blepharotomy, or also known as a cornea surgery, and 3 millimeter of the exophthalmos has improved. Only the inferior lid retraction is still there, which can be corrected afterward if so desired. The things we have to know in the radio imaging study in the thyroid disease is that there are 3 types of orbital volume expansion. In the left one side, you see the orbital fat expansion. Orbital fat compartment has their predominantly increased, and you see the slender extraocular muscles are there. They are the normal thickness. At the central one is the optic nerve, which is stretched very forcefully. in this type of exophthalmos, we have to go for the fat decompression. There is nothing to do with the bony decompression because fat is the main culprit to making the exophthalmos and compression, increase the pressure inside the orbit. In the central one, there is an increment of the orbital volume due to the fusiform belly of the extraocular muscle, the medial rectus muscle and little bit the lateral rectus muscle also involved here. In this type of increase orbital compartment, the bony decompression is indicated. And the third one is where the fat compartment as well as the enlargement of the extraocular muscle is involved. In this condition, both the bony decompression as well as the fat decompression is indicated. Fat decompression or the fat reduction orbital decompression is popularized by Oliveri in 1984. I mentioned that it is easy to perform. There is a high benefit and low risk ratio in this procedure, and the radio imaging will guide which patient is suited for which procedure, and patient with heartile of about 25-26 millimeter can go for this procedure. And there is a good comparison with the bone reduction orbital decompression. This is one of the reference taken from the different studies from 2003 to 2015, where looking at this study, the minimal improvement in the exophthalmos or correction of 3.6 millimeter exophthalmos corrected with the 3.6 cc of the fat removal at the same time, and the maximum exophthalmos corrected with the 5.9 millimeter with 6.4 cc of the fat removal. So in all these studies, there is definitely correction of the exophthalmos with the fat removal. Strabismus is another disaster manifestation in thyroid eye disease, which is very difficult to treat, as our strabismus colleague, they are not very keen to do the strabismus in the thyroid eye patient because those are the fibrotic muscle where you do the strabismus surgery also give unpredictable, that unrealistic result will come with the surgery. That's why beforehand with the patient and patient party, you have to discuss with them that the surgical outcome is variable and we could not sometimes, most of the time, get the proper as anticipated result with that. And mostly the indication for the strabismus surgery in restrictive myopathy is where there is a diplopia in the primary gaze and down gaze or reading gaze is there, where the disease stability is at least 6 months of thyroid status, and the deviation of the amount of the deviation of the muscle is stabilized for at least 6 months, and where the surgery is done, and mostly the supramaximal resection is done in the involved muscles, and they use the adjustable suture, may require the multiple procedure to get the desired correction in the strabismus. And eyelid retraction, as you know that there is a medical treatment for the eyelid retraction is nowadays proceed with the botulinum toxin and triamcinolone in the active stage of the disease, as well as the filler are used due to the gravity, the retraction is corrected. But the permanent surgical correction for the eyelid retraction, I like to go for the cornea guarded blepharotomy, which I performed in the previous video. I've shown that. The various procedure is done that this is the weakening of the eyelid retractor, that's the levator and the mural muscle, or the recession and myotomy of the levator muscle is done. Cornea procedure, this is one of my patient. Both of the upper eyelids retracted in this case. I've done the graded blepharotomy, immediately close the things, and in 1 week, 2 weeks, and 3 months, you see the result of the graded blepharotomy, which will give the permanent result for your patient. This is another patient. In the left-hand side, you see the right eye has retraction of both upper and lower eyelid, where the left eye is normal. After a decade, the same patient came to me. The right eye, operated eye is quite good, and the left uninvolved before I get the retracted. So I did the same surgery then, and both eyes are involved. involved, I have corrected very nicely. This is another lady who presented with significant exophthalmos with the retraction of the both upper and lower eyelid. We did the fat decompression with the blepharotomy. And this is my very early patient when I became just the oculoplastic surgeon in 2004 and 5. Also presented with the retraction of the both eyelid. We did lid retraction correction only with the blepharotomy, and our lower eyelid retraction corrected with the recession of the inferior retractor with the spacer. I put the spacer of this, what is it, hard palate graft taken, and they put as a spacer, and see the result. It is a very much reasonable and realistic outcome came with this. So with this, I'll say that ophthalmologist, as being we are in practice, we are the key player to manage along with our colleagues, endocrinologists for the thyroid eye disease patient. As we know that there is a lot of patients are diagnosed with the thyroid disease, and we expect more thyroid eye disease patients are coming in our practice in the future time. With this, I conclude my talk, and I would like to once again thank you to the team of the REMEH-ORS Hospital for the beautiful international conference, and thank you for your attention. Thank you very much.
Thank you, Professor Dr. Rohit Saiju, for the wonderful talk. Our third speaker of the session, Professor Dr. Sagun Joshi, is a distinguished vitreoretinal surgeon, former head of department and now the executive director of BP Koirala Lions Center for Ophthalmic Studies. He is also the head of vitreoretina and phaco training at BPKL-COS. He has received several distinguished awards, including the Chiranjeevi Gold Medal Award and the Jana Prabal Award from the President of Nepal in 2018. He is the eye surgeon to the Honorable First President of Nepal, Dr. Ram Baran Yadav, and past President of Nepal, Vidya Devi Bhandari. He is also the eye surgeon to the late Honorable Prime Minister Sushil Koirala and the past Prime Minister of Nepal, KP Sharma Oli. It is my immense pleasure to welcome one of the greatest phaco surgeons of our time, Professor Dr. Sagun Kumar Narayan Joshi, to present on the topic intravitreal injections in SAPU. Thank you.
Hello. Thank you, Sanket. Really glad to actually have my dear friend Rohit present before me. We passed out together, and he became an oculoplastic surgeon. I became a phaco and vitreoretinal surgeon. But I had immense interest in oculoplastic. I really wanted to make people beautiful. But my friend took care of that. And I remember that whenever we had our parties, our gatherings, I was the phaco surgeon, the vitreoretinal surgeons, and I was surrounded by old people. And this guy had all the young and beautiful girls around him. And that's what I felt really jealous about. And but now I'm okay, because I've become old too. And I thought big eyes are beautiful eyes. And after seeing your presentation, Rohit, I feel a little terrible about that now. I saw those real big eyes. And in fact, when I first met my wife, I didn't know she was a myopic. She was like, she had such beautiful, large eyes. And then I later came to know that she was a myopic. She was wearing contact lenses. And now she has thyroid disease, but doesn't have thyroid eye disease. Anyway, I'm jumping to a topic which I think all Nepalese are very aware of. And before that, I would like to thank some people. I would like to thank Dr. Ranju, who has been a pioneer in doing research in this field of SAPU. And so I want also to thank all my faculties in BPI Center, my mentor, Dr. Jeevan, Dr. O.K. Malla, Dr. Madan Upadhyay, Dr. Shashank, and all other faculties, and my dear residents. without which this presentation would have been impossible. Special thanks to Prasanna. Dr. Prasanna, I want you to stand. Where are you? Yeah. So this guy, he has this talent. And I'm not the one who actually, I've been giving the input. I'm the one who did a lot of things, but he's the one who laid out the presentation. So he's this guy who really has a lot of hidden talent. Thank you, Prasanna, really good. I'm so impressed by you. So, as the name goes, Shapu, S-H-A-P-U. Everybody nowadays have shortcuts, like you just said, Reukai, R-E-M-E-H. So we have BPKLCOS, that's my institution, BP Koirala Line Center for Ophthalmic Studies. It's so long. By the time I finish it, it's like everyone's fast asleep. So, we also have seasonal, hyperacute, pan-uveitis. I'm sure some specialists, especially maybe Sanjay, must be wondering what the Shapu is. Are you aware of Shapu? Yeah, you are. So wonderful. That's wonderful. So, Shapu, I'm sure everybody in Nepal, especially Indra, you must have seen a lot of cases of Shapu. Yeah, he's one of these guys. He's from Pokhara. So this Shapu, a lot of Shapu cases from Pokhara. And this disease is quite new or not known to the West, if you agree. You, yeah. So let's talk a little bit about Shapu. I'm not so much, but I just innovated something which, this is a very blinding disease, and it's still a dilemma. We know that something has caused it, but we really don't have a cure for it. And we are working left and right. We're trying our best. And we, in a third world country, we're not in the States. So we can't do all those things which you do. But at least we can try. And we've been trying. And I'm sure, if not us, there will be somebody in the crowd who will find the right cure for this. I'm not saying what I've done is the right cure, but I'm sure this is the way to go about it. Just get me this. Thank you for putting my photo. I look quite handsome. So, it was reported from Nepal since 1975. Many of you were not born. I was born. And the surprising thing was, it was always coming in odd years. About this disease, I think Dr. Jeevan may be knowing most, because he seems to be the most eldest person here. So it started long ago, but it was identified in 1975, and surprisingly, it did come yearly, but it came in a storm every alternate years. And we found out that it was very seasonal. Post-monsoon, the season was like mostly August to December, but it was mostly during those holidays, where the monsoons would stop and we would have sunshine and, good weather. And that time this disease would come. And the cause, not known till date, infective or immunological. There is a lot of debate. Some people say it's infective. Some people say it's immunological. And both are not right or wrong. Both are not right or wrong. So it's believed that this etiological agent is this wonderful moth that is flapping around. I'm sure all of you have seen. This time in Kathmandu, we see a lot of it. I can see Angela shaking her head, So I'm sure you all must have seen. I saw a lot in my eye center this time. These moths just fluttering around these bulbs, especially our LED bulbs, the white bulbs. It looks beautiful. But after this disease everyone known about Shapu, like even our helpers, like, oh, this moth, I need to get away from it. I need to get away from it. Otherwise, everyone goes close to it. See this moth. But now, any white moth, no, 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 we don't want to see this. There's evidence suggesting that the disease is probably due to exposure to some toxins from this moth. These moths, they have these fine hair follicles at the back of their body, probably to protect their eggs. And it's believed that the toxins are released from these hair follicles. And surprisingly, Shapu is a disease predominantly in children. And male, female? No. It can attack anybody, but predominantly young children. But doesn't mean that we don't have older children. We do. And invariably it is one eye involvement. That's why immunological hockey, unilateral involvement, and there is no recurrences. We don't have recurrences. And it's usually absolutely sudden in onset, and the eye is absolutely red, no discharge. There's minimal pain, and the alarming thing is there is drastic loss of vision. Patient is blind within 72 hours. Blind. And there is this white pupil in a red eye. So, just scary, isn't it? So, time is sight. Rapid progression from mild to severe stages in 72 hours. By the time, especially in a government hospital like us, where everything runs so slow, by the time the patients come from the emergency to us, they've already lost a couple of hours. And the patient would have already lost sight. By the time the patient has already got infected and comes to us, they've already lost so much of time. And then when they come to the hospital, and then from one place to another, they already lose more time. And most of the time, most of the people are blind by the time they come to us. So you can see that the severity, mild, moderate, and severe. See the vitreous echo shadows? That's how it looks like. So see these patients, how they come. Sometimes, really, some of them have watering. Some of them are quite quiet, very strange. I said some of them are quite symptomless also. And some of them come with really discharge, red eye, watering. There are some of the patients that have come to our hospital. This was a patient had like proptosis. It was diagnosed as, in fact, panophthalmitis. And there was full pus. You can see the white pupil there. It was that. And that's where we take the patient into the operation theater and give the intravitreal injections. And see this patient, how uncomfortable the patient was. And after the intravitreal injection, at least the patient is comfortable. I cannot guarantee the patient is seeing, but definitely very comfortable. And I'll tell you a little bit about the intravitreal injections. That's what I'm more interested in. See this? This is another patient came with swelling, little child, and we gave intravitreal injection, and the patient definitely was much better comfortably. Let's talk about a few of our cases. We have had a lot of cases this year, and surprisingly, most of the time, this case used to be in a place in the Pokhara region, Kaski region. I think because of climate change, there's been a shift towards Kathmandu now. Nepal, Kathmandu this time is a little warmer than last time. I'm sure everyone is aware of that. And you probably would be in more thicker jackets today. But this time it's a little warmer. And we had these moths, massive number of moths in Kathmandu. I had them killed, a lot of them killed. In fact, Dr. Ranju had bought all these moth traps to send it to Pokhara to Indra. Indra, did you receive? You didn't receive, I think, because we had enough moths in our place. So we were just catching them. You did? Did you receive it? You did, okay. Actually, we didn't have to send them because we had plenty here. So there was this young patient, 6 years male, contact with moth while sleeping. And children, they like to touch moths, butterflies, and they're the ones who really, anything that's moving, they like to touch. And the duration of symptoms by the time they came was only 2 days. Aha. Technology is a disaster. Anyway, so before I go into that case, because I need the video presentation, is somebody going to look after the lights? Inamani? Actually, bandina. So people always did a lot of studies on this, taking out intravitreal samples, sending it for a lot of studies, but we really didn't come to any conclusion. Some doctors said it's infective, it's viral, there are some viruses isolated. Some doctors said it's this bacteria, some doctors said it's that bacteria, some samples said there's nothing in it. So it had conflicting views. So we really don't know what the cause is. And we are injecting antibiotics, we're injecting steroids, we're injecting different type of IV antibiotics, we're using oral steroids, we're doing vitrectomy. So a lot of things were happening. But we still were not getting good results. Everything was done. Samples were done, different studies done, still confused, don't know what to do. Patients are going blind, and many times we took the patient for vitrectomy, and we cleared the pus off, but the patient would suddenly go into phthisis. Terrible. So we had this patient, only 2 days. Visual acuity of the effector at presentation was just perception of light, and PR was inaccurate. Sometimes children, it's very difficult to say whether they can, they can't comprehend. Severity of the case, cells 4+, flare 4+, exudates in the anterior chamber, and we definitely could not see the posterior segment. Vitrectomy done. Next day, intravitreal vancomycin, ceftazidime, dexamethasone given. But we mostly don't do a total vitrectomy, just do core vitrectomy, like Ronald said, when you have this necrotizing retina. You don't want to touch, it may just detach. So we just do core vitrectomy. So this was what was done. And the next day, 5th day, the left eye the IBA became soft, less than 5. I thought it's going into phthisis. Then something struck my mind. I was using a lot of, I use this cocktail drug, which I call TDM. Triamcinolone, acetonide, 4 mg in 0.1 ml, plus dexamethasone, 0.4 mg in 0.1 ml, and moxifloxacin, 1 mg in 0.1 ml. So I make this cocktail of 0.3 ml in my insulin syringe, and I just inject in 0.05 ml. So I mix it up, and I made this cocktail because I don't know what this was. So it was basically triamcinolone, dexamethasone, and moxifloxacin, mostly concentrating on the steroids, short-acting and long-acting. And the antibiotic, I need a good night's sleep. I mean, a lot of doctors said it's infection, and it's infection. And Moxi works very well for a lot of organisms. So that's my good night's sleep. So I got this thing, and I labeled it as my TDM. And the cost is less than $2. The cocktail costs less than $2. Very easy. Cost effective for my countrymen who can't afford it. On the 4th week of follow-up, the child came with a visual acuity of 6.6. There. I'm just showing you the timeline of visual acuity change. You can see how it improved. So I did this. It was just out of luck. I just said I was using this in some of my uveitis patients. It was easily available, cost effective, and I've been teaching my residents. And I do it, what I realized is I get these small kids, and to prepare them for GA, the anesthesia, this, that, it's a big hassle. So before we used to take all the taps, a lot of taps have been taken, but this time I was more interested in saving sight for the patients. So the moment the patient comes, I just take them to the minor OT, put xylocaine drops, cuddle the child up with some, wrap him up, and I just inject straight away under topical. I don't wait even a minute. I don't wait any time. And I straight away do that, and I tell my resident, tell me what it is like tomorrow. And the resident calls, sir, today the child is much better. So that's made me feel, yes, this is probably, I may be going the right way. Yeah, that's what I show. Some more cases, how it improved over a period of time. And I've been using this injection left and right, and it has shown, if not improved visual acuity, at least relieve the symptoms also drastically, especially in those patients that had no vision and had severe, like they were referred to me as panophthalmitis. So that's another case there after the injection of TDM. So sometimes, out of the blues, we do have cases like this also. 21 years female, previously diagnosed as viral conjunctivitis, complains of diminished vision, redness, photophobia, only 3 days. And was diagnosed on ultrasound, severe Shapu. This was what it looked like in ultrasound. And then I gave my magic lotion, and that's what happened. There's VCD, and then TDM. So initially, VCD, vancomycin, ceftazidime, dexamethasone. But when I put this triamcinolone, dexa, and moxie in that amount I kept, there was drastic improvement. So I said, cheap drug, wonderful drug. Case 3, another 21. We gave a lot of injections, just showing you some good cases. There were some bad cases too. A lot of bad cases that lost sight. When we present, we don't like to show the bad cases. But I can at least tell you one thing, that the bad cases, at least they felt comfortable. They felt comfortable. Just the other day, I think my fellow Subhash, are you here? Subhash. Oh, okay. So we had this patient, actually was a case of another Shapu, and they had done cord vitrectomy, and after a month, the patient was going into phthisis, soft eyeball, very soft. And it was referred to me by Ranju, and Ranju said, sir, this looks like a hopeless case. And I said that it's going into phthisis. I said, let's try a TDM, no harm. And we did give one, and the pressures bounced back. And the week later, it was fine. It was fine. Right eye vision at presentation, counting fingers, multiple moth hairs were seen on the cornea. Surprisingly, we don't always see moth hairs on the cornea. But in some patients we do. In some patients we do. In some patients we don't. Multiple corneal infiltrates, constricted pupil, muddy iris, fibrinous exudates in the anterior chamber. And was diagnosed as severe Shapu. Same day, vitreous tap, intravitreal. Old people, a little older, we tap. Younger patients, I don't tap, I just inject. I can't afford to lose that sight. And there goes my then magic cocktail. And I always give it in the inferior quadrant. It's very easy. I've taught all my residents, I called it the Joshi technique, and I've taught all the residents how to do that. Just take a few seconds. And on follow-up, the visual acuity was 618, absolutely pain-free. Beautiful. The patient was happy, smiling. You will see those moth hairs. Can you see the moth hairs? It's marked. I'll just show you the next one. Can you see those moth hairs? There. That was the hairs. Some patients you see these moth hairs. Just today morning, or last night I remember, my door handle, I was going to open it and I saw those eggs with lot of those moth hair. And I just told Sunil, looks like the gazellina moth, you know, the hair follicles. And I took a tissue paper and I just did. And all the hair follicles started flying off. On these two people, just ran away. They ran away, literally ran away. So it's just scary, how scary it is. So, you know, it can go to anybody. So you can see that there are these hair follicles. All the hair follicles. So, in conclusion, still a dilemma. But I feel there is hope with this drug. Simple, cost-effective. We do a lot of researches, we do this and that. Yes, that should go on. But if you don't have something, you are doing that, you still don't have something, I think this will help at least the patients. So my sincere advice to all those who are actually seeing SHAPU, we still don't know the cause, we still don't know the remedy, but this TDM does help. Intravitreal injections offer a quick, reliable, and very effective mode of therapy to tackle challenging diseases like SHAPU. Thank you. Yes, a little time home message. Never ever delay in providing aid, be it at night or day. Seconds save sight. Children seem to be affected more. Be compassionate, treat with care. They have decades of productive life ahead. You know, when it comes to vision sight, it's question about sight. Research comes later. It's sight first, then research. Not research first and then sight second. So as a doctor, most important is that. Yes, you have to have research because we need to find the answer. But when it comes to sight, we can't delay. An intravitreal injection, rapid, a sure short way to provide precise and targeted therapy. Some of our memories. And that's me in my presbyopic glasses injecting with topical xylocaine right in the center. This child just came and we just said, okay, wrap the child up, let's do it. And all my residents were around me and just helped me. And the patient did wonderfully well. It's all about hard work, persistence, and team effort. Thank you. That's my institution.
Thank you, Sagun sir, for the wonderful talk. Always a pleasure to listen to you. Now, with great pleasure, I would like to invite our next distinguished speaker, Associate Professor Dr. Indira Paudel. She currently serves as the President of the Glaucoma Society of Nepal and is the Department Head of Glaucoma at the prestigious Tilganga Institute of Ophthalmology with her expertise in pediatric glaucoma. Among several awards, she is the recipient of the prestigious Arvo Weaver Award, was recently felicitated in the ACOIN 2022 India. She is one of the mentors for the CATCube 2022 and is one of the founder executive members of the World Ophthalmologist Women's Society. I welcome Dr. Indira Paudel for our talk on the topic glaucoma services in Nepal. Welcome, ma'am.
So, I'll take a moment. I think Professor Dr. Sagun Joshi and Professor Dr. Rohit Saiju, they need to depart early. So, I think we'll be giving away the token of love to them. I would like to request Scott Hamilton, sir, to give away the token of love to both of the professors.
Namaste to all and good afternoon. So, we are towards the end of the day. I don't want to take too much time. And here I want to show this picture, which, takes a million messages. So we ophthalmologists in Nepal are living for sight. That means in one of the picture you can say a young lady with bilateral blindness with cataract, and the other side is another young lady. I consider myself still to be young, so fighting for cataract blindness. Whereas in contrary, I'm a glaucoma specialist in this country, and so it's a leading cause of blindness after cataract, and glaucoma being first major cause of irreversible blindness worldwide. And also in Nepal, the 1981 blindness survey, we have about 3.8% of blindness from glaucoma, and Bhaktapur glaucoma study was about 5%. So most of the glaucoma is diagnosed when there's significant amount of vision loss. That's why I wanted to show that picture of the lady with bilateral cataract. So we don't know, whether she has glaucoma. We just do the cataract and we don't see the posterior segment, and we are very happy with 6/18 vision post-op. Oh, she has 6/18 vision. She was bilaterally blind, but we don't know how much glaucoma somebody must be having. And it remains an undiagnosed disease in Nepal as in other countries too. So it's not timely diagnosed, and especially here, someone has to be taken in a basket where they collect grass. So this patient is a picture that I've taken when I go to the cataract camp. So I, hopefully thought she had cataract. Next day when I saw the patient, her vision was just hand movement, and we didn't have the other equipment with us, so we just saw a direct ophthalmoscope. She was total cupped. So even children in Nepal, one picture, it shows child is brought by the mother with lot of hope, and she's already having, both eyes, both thalamus with dense corneal scar, and we had to defer her back home, which we don't want to do without even doing any investigation. Spend a lot of money traveling to reach our hospital, and the other child was brought on time and was operated in both eyes and already looking a clear cornea, hopeful of sight of vision. And blindness in glaucoma, so we know that there are 60.5 million people blind, and in Asia, 47% resides here. And primary open angle glaucoma is more common, and angle closer glaucoma is less common. But many a times, angle closer glaucoma is undiagnosed, so maybe we are missing out there. And more devastating is the angle closer glaucoma. Early intervention is needed, not just medical management for treating angle closer glaucoma. And so prevalence in Southeast Asia, so Bhaktapur glaucoma study also shows the prevalence of 3.0 in of POAG, and 2.5 of primary angle closer glaucoma, 0.4, sorry. And so we think that this is a small population-based study, so cannot include the whole country. And causes of blindness, population-based in Nepal. In 1981 and in 2010, we still have glaucoma like less than 5%. Maybe it's not diagnosed. So challenges are eye care services in Nepal, the geography, the population scattered, infrastructure, eye care services are not so proper, though now we have lots of eye hospitals. And disease prevalence, we are very unaware. We always think that, oh, we have, a lot of Mongolian race, we have this kind of glaucoma. So we just say, but we are not sure how the disease prevalence here and the economy. Definitely it's a big burden when someone is diagnosed with glaucoma. And so that picture above, again, here, yeah, this picture above, again, the geographical terrain. So actually, when I went to Manang, it's a mountainous area, pretty far away. This patient came in a pony to get his cataracts out. So happily went back home. So the geographical terrain is very difficult, and the inaccessibility to the eye care. So someone has to wait for eye camp to get the eye service So how can we, even diagnose glaucoma there? Luckily, we had a slit lamp, so even that gentleman had primary open angle glaucoma, though he had some vision restored from the cataract surgery. Either they have to take a flight to their nearest place like Kathmandu. Somebody has to come in a helicopter or an aeroplane, which is pretty expensive. And sometimes they go back, with they come with hope, with such difficult terrain, and they have to go back, saying that nothing can be done for you. So this is how glaucoma is here. And in this picture, we can see most of our hospitals with the red triangle are located in the southern part of Nepal. And in the hilly region, we have very less hospital. And that's the area where the geographical terrain is very, very difficult for a person to even reach a hospital, have to travel 3 days. So someone who developed acute angle closure glaucoma, by the time they arrange money, reach the hospital, the prognosis will be very poor. So in Tilganga Eye Hospital, the glaucoma department, we have various sectors, the OPD and the surgeries and training department, and we do a lot of outreach camp, research, and patient awareness program. And awareness program include not just patient care, but also on Saturday, once in 3 months, we have patient awareness program. So we have also conducted community services where, when we have, in most of the doctor hospitals in Nepal are doing a lot of eye camps. So in those camps, like we have made our resident do their thesis so they can do opportunistic screening. So we had taken basic equipment there and screened the patient and brought them back to our hospital. And also training of ophthalmic assistants, because they are the backbone of our country, and many places they are the primary person to see the disease. So most of the time, if it's missed by them, then glaucoma doesn't worsen overnight. So if we can detect on early time, we can do something for them. We don't have to send someone back in the same basket, they were carried to us. And even public awareness, we started back then in 2003 and still going on every year. Now we have so many glaucoma specialists in the country, so we are able to do this. And the impact of awareness programs, that has also led us to continue these programs. And so now with our awareness program in glaucoma, the other subspecialties also are doing such programs, in periodic basis in our hospitals and in other hospitals of Nepal. And here, along with people from different social workers, our patient who are visually impaired, they are helping us out for the awareness in our country. And the disease prevalence, we have a lot of children in Nepal with glaucoma. So it's very difficult because sometimes they don't reach the hospital on time. And sometimes they reach the hospital on time, but they don't have the money. And so most of the hospitals don't have the facility to operate them. So they will have to refer them to the tertiary hospital, which again cause a big challenge. So by the time they arrange money and reach the hospital, maybe sometime it may take months to years. And then we lose the child. So I just want to thank the foundation, the Dule Foundation supported my 2 children. So I saw one child few months ago and the child got lost. So Mr. Kalanji, he's here. So he brought the child back to me one day and I said, where did you find him? So when they had gone, they brought this child and, they supported us. So it's not just the Reukai they are supporting, so we have a lot of these kind of great help, and that counts a lot. Though it's just 2 children, somebody got aside. And again, the poverty. So again, here they are, in extreme condition. Again, this is a picture from the cataract camp. And the screening, so large screening is very difficult because of the cost, infrastructure. Glaucoma needs a lot of equipment. We don't have so many portable equipment, so it's very difficult. And sometimes we just have to do some kind of opportunistic screening in cataract camps, so case detection can be there. And I don't want to elaborate this so much. We have come out with some data, but I don't want to elaborate so much in this. And also the research and community. So Bhaktapur glaucoma study was one of the first epidemiological study in Nepal. And also we have compared some screening of glaucoma by paramedical staff in remote areas of Nepal. So we have used portable fundus camera, and also we have used iPad apps. So here you can see in this picture the visual field done by Humphrey and iPad, and again the validation was done with the University of Iowa, and also the undilated picture with the Pictor and dilated with Topcon. So in Nepal, we have potential of teleophthalmology for screening glaucoma and for referral, because unnecessarily, we don't want the patient with cup-disc ratio of 0.4, 0.5 traveling all the way, arranging money, taking a flight, reaching us and spending so much money, and then we say, you have nothing, don't worry about it. So teleophthalmology plays a very good role in our community. And the service barrier between the rural and the urban setup is, we can see in this picture, the urban, they go to big hospitals and get all the facilities, with modular OT. They have the best doctor of the country. They can get service like that. But in rural, I hope you recognize something that, so the women, they are the basics of household and everything. And the women are the one who get access there. So they find treatment to their disease when they go to the camp. So this is another scenario. And here we have, in our country, in back then in 2008 and 9, we just had very few glaucoma specialists in the country. So it was very challenging for us to serve our glaucoma patient. And our population is scattered in the Himalayan region, difficult terrain, and also the Tarai belt. So we have started the glaucoma fellowship about a decade ago, and have trained more than 32 glaucoma specialists in the country. So this is a very good ray of hope for us. And the training continues, and the training of ophthalmologists is not just limited for Nepal. So we have glaucoma fellows from different parts of the world, and public awareness is being continued till now. And we have this patient education book, and the classes has been there, continued to 2005. And finally, after years of difficulties, we have a Glaucoma Society of Nepal, which was just established in 2019, and the COVID hit us. So we are still like born, neonate. We still haven't gone out of that. But we are so happy to announce that we are so many glaucoma specialists in the country. And at this platform, I'd like to congratulate Diksha. She's also one of our glaucoma fellow from Tilganga. She, with the Dr. Chris, she was able to perform the first implant in Reukai Hospital. So, more of us are doing more of challenging glaucoma surgeries, and we are getting a lot of secondary glaucoma because diabetic retinopathy and their surgeries, we end up, and the cornea transplant, we end up with a lot of secondary glaucoma, and we have to, go for implants. So the scenario is different than before. And in conclusion, what we know is, we all know that glaucoma is a disease of the aging population, and primary angle closure glaucoma causes more morbidity and visual morbidity than POAG. We have to recognize the disease on time, and maybe surgery is the best treatment choice for primary open angle glaucoma. Patient coming with cataracts, we are already, like, Nepal is very ahead in cataract, but we still have to, take a long step to glaucoma. And we have to focus on case detection, medicine versus surgery. So it's a big challenge. We cannot send the patient with a drop who cannot come to us for follow-up. So maybe primary tube is also another thing that we have to keep in mind. And some of our hospitals, we already have SLT, so that's also a good thing for us. And we should conduct frequent glaucoma awareness programs at primary, secondary, and tertiary level of hospital. So again, patient, they are waiting for post-op examination after cataract surgery. Me, myself, being a high-volume cataract surgeon, so these were the patient that, they were waiting for me to open their iPad. And I always, at this time, when I was young, I was so energetic just to see how much vision, how the cornea is, what's my number, how many cataracts I can do in a day. So that is no more my dream. My thing is, whatever I operate, I just feel if I don't have any equipments, I'm so worried to come back to my home, leaving them behind. I don't know who have glaucoma, so I don't have the answer for them. Do I have glaucoma? So we really have to see our post-ops. We should see our fundus. We should see the disc at least for those patients which we didn't see before we count the numbers. I do 100. I've crossed my century in a day. So these things have to be taken, we had to fight for cataract blindness in the country, but I think most of this is being addressed now in Nepal. So we really have to, glaucoma is a big burden financially, and one person blind in a house is a big challenge, So with this, I'd like to thank you so much, and thank you everyone for giving me this platform to be here today. Thank you. Namaste.
Indira ma'am for the wonderful talk. Moving to the next presenter, we have Dr. Kishore Raj Pradhan. Dr. Kishore Raj Pradhan is an accomplished refractive surgeon. He has performed over 30,000 cataract surgeries and is recognized for his global contributions, including the development of Atos femtosecond laser. As the medical director of Matrika Eye Center, Kathmandu, and Matrika Eye Foundation in Birgans, he collaborates with the London Vision Clinic to provide free surgeries in rural Nepal and serves as the key opinion leader for Carl Zeiss Meditech, Germany. With immense pleasure, I welcome Dr. Kishore Raj Pradhan to present on the topic, Concepts on Refractive Surgery. Welcome. And I would like to request all the delegates who are seated at the back, please come front so that the room appears quite full, and then we can get good pictures of you also. Thank you.
Please do come forward. Good afternoon, everybody, and thank you, everyone, for sitting back to listen to me. I'm not a very great speaker, and in fact, I'm very, very down today because my mother's in the hospital. I've been up, awake the whole night. So whatever he said about me is like, makes me sound like God, but one thing we have to understand, that we're human beings, and we always make mistakes. We have a lot of complications, and a doctor's life is full of challenges and complications, and how we manage them. Yes, I am a consultant to Carl Zeiss as well as the Schwinn company. But today my talk today is like very, very basic, because we do not have too many refractive surgeons in Nepal. And if I start talking about all the hi-fi stuff, people start sleeping. Most of the time, the first row is always sleeping. And in fact, very good friends of mine. I don't know if you've heard of a person called REMEH-ORS. REMEH-ORS is, in a pentacam, you have Belin Ambrosio. It's a scan. And REMEH-ORS is one of my very good friend from Brazil. He's a refractive surgeon. He always meets me wherever and says, Kishore, today I'm going to come and listen to you. And he's always sleeping on the first row. So a refractive surgeon can sleep, so I don't mind if you're sleeping, all right? But the topic today is just basic concepts. Because every time I meet somebody, any ophthalmologist, the first thing they say is like, even Dr. Ruchi, when I met her last time, she said, Dr. Kishore, there was one person with a fat glass, and I was referring the patient to you. I said, no, that's the patient who will not have surgery. And she's like, I'm a retina specialist, I don't know whom to send to you. So my talk today is just to make you understand what things are, what the way we think, and the way we refractive surgeons think, okay? And the way you think, what your fears are, something like that. So the statistics over here, very simple. 15 million people are myopic in Nepal. It's a growing figure. 100% of the people are presbyopic after the age of 40 years. This is somebody, we all know that. 1 out of 90 people are visually impaired or undercorrected. Refractive errors, the most weirdest reason is cannot afford glasses. The weirdest reason to be blind is you cannot afford glass. And we do have a lot of people, 1 out of every 90 persons in Nepal are blind because, I wouldn't call them blind, like they don't know what their vision is because they don't have glasses. Or even if they are told to wear glasses, they don't have the money to buy one. Or if they buy a pair of glasses, the whole month can be affected. The fooding and the school children, something like that. This is such a weird thing. So again, 15 million is about 30% of our population are myopic, unlike China, where 90% of the people are myopic. Okay? I'll just give you a very simple example over here. The first thing I tell you about is diarrhea, because my mother is always having diarrhea or something like that. And I wish to cure it permanently. When you get a disease, when you get something, like a cough or a cold or pneumonia, you get a tumor in your brain, you get an abscess, you get a fracture on your foot, and as often you get a cataract or you get an whatever you do, whatever you get, you want to cure it. You want to cure it permanently. But with refractive errors, glasses is there, but it's not a permanent cure. Yes, you can see very well, but in the morning, I was minus a million also. So every morning when I used to wake up, the first thing you have to grab is your pair of glasses, which you wish you didn't have to. So the burden of wearing these glasses again, a very simple example. Somebody over -4 or -5 is as bad as these crutches. Somebody with a -5 glass, spectacles, I'm sure you can go to the bathroom at night in your own house. But if you're in somebody else's house, you need your glasses to go to the bathroom. And it's exactly like these crutches, you need them to go to the bathroom. So these glasses are like these crutches. They really pull you down. In any aspect, into the army, the sports, swimming, anything. And I'm sure nobody wants to wear glasses. And the worst is presbyopia. And you'll get it. I'm telling you, it's going to be on your head. He's got his glasses on his head. And you'll be looking for it everywhere. You'll be looking for it. I have dropped at least 3 of my glasses in my toilet. I looked, I go to clean, and the glasses will fall on the commode. It's very weird. And when you are 40, 45, you find it very funny. Oh, I'm growing old. When you're 50, you want to kill the world because you can't see your menu, you cannot see things, and you're getting angry. At the beginning, when you become 40, 45, you're very happy that you're growing old. At 50, definitely you don't want to wear reading glasses because you cannot see things very well from here. So where are we now? Out of the 15 million, besides glasses and contact lenses, at Matrika, we do about, see what's happening in Nepal, the permanent, we are doing about 1,000 refractive surgeries at Matrika Eye Center. Last year at Tilganga, they did about 350, 500, I think, I don't know. Taparia, Biratnagar, there are another 2 lasers there, that's it. So of the 15 million people wearing glasses, we have not even treated 2,000 patients permanently. We've gotten rid of. And most of the patients who come to me are from Australia. Most of them. Hamrai Nepaliyahru tara Australia bata. So what are our fear and myths? The biggest fear that is created is from the fraternity itself. If somebody wants to do laser surgery, the first thing you want to do is ask a friend. Anybody can wants to go and ask a friend who is related in the ophthalmic field. So someone knows an ophthalmologist. If that ophthalmologist is a cornea specialist, the cornea person says, oh, refractive, don't. Why do you want to touch the cornea? It's going to go thin. Ah, the flap is that, this, that. No, don't. The retina guy, I was in training for retina. I was taken into retina into so many hospitals. When I was doing the first thing, I said, refractive surgery, are you mad? You are myopic. You will get retinal detachment. And when I'm doing your retina surgery, the flap is going to come off. We'll have to put a lens on your cornea, and I'll be doing all the vitrectomy, whatever. And it's disaster, don't do. The glaucoma will say, the cornea is thin, the pressures are going to be different, your visual field will be all different. Don't. UVI will say, don't ever touch. You know? We have a very senior UVI specialist here, Dr. Anu is here. She finally, you know what she did? She brought her sister for refractive surgery first. She did her sister's surgery. And then after 2 years, she came and said, I said, you're not qualified. You know? And now she's struggling with her presbyopia. Okay. The optometrists, they are scared that they will lose their glasses. This is the biggest problem with the optom group. La, hamro to chashma, hamara chashma chala jayega. You know, our glasses will go if the refractive. But think is 15 million glasses being sold every year. And you're talking about 1,000 refractive surgery. Okay? Complications. These are the fears, like complication. What happens if you get a complication? What? Refractive surgery is pretty safe. So I was trying to give a similar talk in Birthamur last week. And the head of the Mechi Eye Hospital, he's wearing thick glasses, -8, Dr. Purushottam. He's sitting right in front of me. He was in his hospital lecturing. I asked him, what's the cost of your glass that you're wearing? He said, 25,000 rupees. That's around $200, made at the Drishti Eye Hospital by another surgeon in another hospital, because it was 50% less. And we are doing refractive surgery in about $800. Smile, LASIK, whatever. So can you imagine if this person is going to make 2 pairs of glasses every year, how does it work? Is it expensive or cheap? So refractive surgery over here is so much cheaper than making glasses every year, contact lenses every year. And contact lenses are not less complicated. You can get keratitis, all the things that can happen. So this is the first line I've already talked about. So the biggest problem here is the lasers are very expensive. That is the reason why refractive surgery is expensive. I'm also in a group called the Refractive Surgery Alliance by a person called Guy Kurzian in the US. So one of our main goals now is to pressurize these laser companies to make lasers cheap, and we can do high volume, low cost, like how we work here in Nepal. So Guy Kurzian had come to Kathmandu to start FDA trials for SMILE in the US. So Guy was here. So we are always trying to make refractive surgery low cost, high volume, like the Lahan Hospital. Like, you know, they do 500 surgeries in one day. So if we could do refractive surgery, something like that. So what is the main difficulty again? Training is so difficult. Training a refractive surgery can be done by anybody. The most important thing, the most important training is looking at the scans and to decide whether to do surgery, not to do surgery, or what to do. The best is, if you cannot decide, just leave it. Something like that. Again, training is a lifelong procedure because every person's corneal topographs, they look different. You think it's very easy, this is normal, it's not. At the beginning, every cornea looks like keratoconus. You don't know what to do. I have 2 surgeons in my clinic more. Every day we sit and decide, what do we do with this? My second surgeon he's doing refractive surgery almost 5 years now. And still we have to keep. I was talking to Dr. Sanjay, I have a patient problematic, this is happening. And he's trying to help me. I'm talking to somebody's asking me. It is a lifelong procedure. And in fact, it's the same for all the fields. Retina, glaucoma, you don't know what to expect. You do cataract surgery, you do retina surgery, and tomorrow you don't know. Retention of manpower is again very difficult because refractive surgeries are very, very aggressive people. They want more and more money all the time. Teamwork and coordination is very difficult in all the hospitals. Sometimes you can have very, very big hospitals, very coordinated, and sometimes you can have small clinics who are really absurd, running around and all haphazard. And hospitality is again very important in refractive surgery. In fact, now hospitality is the main thing everywhere. Nepal, there was a time where we used to see patients, and we were always in a rush. And if the patient is a little slow, we used to pull out a hand like this and catch the patient in the hair and pull the patient in the slit lamp. You know, there was a time. You do that now, and the patient will pull out his hand, and then he'll bang your head on the slit lamp 10 times. So now it's changed, but still, when you go to the US or when you go to the UK, there's so much hospitable, so much more. So when I went to London to do my fellowship, I was sent from here because I was very soft-spoken and smiley or something. And I went to London and they told me, don't talk to my patients for 2 weeks because I sounded like I was going to beat them up, you know? So my professor used to teach me how to talk. Say hi to the patient. Say hi, Kishore, say hi. Introduce yourself. Smile, all the time, you know? So for 2 weeks, it took me how to do that. And Nepal is getting better, but we are still very, very behind. And it's very important for every field, not only refractive surgery, for retina, glaucoma, just to say, hi, I'm Dr. this and this, I'm Dr. Anu, I'm Dr. Indira, I'm Dr. this, I'm Dr. Kiran. I'm going to see your thing, you know? And suddenly there's a big light. We could just say, I'm going to put a big light, and the patient is ready. And the patient gets startled, come on, you're wasting time, yeah, you know, and we got to be more hospitable now. So the treatment-wise, 90% of our treatments are in the cornea, on the cornea. So we treat myopia, myopic astigmatism. You can go up to 14 diopters in the cornea, but they all depend on how strong your cornea is. You can also treat higher order aberrations. Okay, so myopia, hyperopia, astigmatism, they are lower order aberrations. Okay, very simple. But I doubt 95% of people over here in this room have not had a proper examination. I'm sure. Ophthalmologists, the worst. I don't know how many people have ever gotten their eyes dilated and had the air pressure or anything like that. I remember 12 years back, Dr. Indira telling me, you're a glaucoma suspect. After that, I didn't ask anyone. I haven't asked anyone to look into my... Really? Do you remember? He said, you're a glaucoma suspect. Till now, nobody has looked into my eye after that because I might have glaucoma. We doctors are the worst patients. My wife is a doctor. You know what she does? Sometimes I'm sleeping and tick, there's a big pain in my finger. What are you doing? I'm checking your sugar level. You know, because I hardly go and check my blood sugars because my blood sugar is high and tomorrow I have to start exercising, no food, nothing. Doctors, most of the doctors are like this, you know. So the higher order aberrations are, we hardly even ask our patients what our problem is. Do we ask our patients, like, do you have difficulty with driving at night? Do you have, your vision is a little tilted, or do you see halos, or do you see starbursts, or do you see sometimes you could have no refractive error like the lower order, myopia, hyperopia, astigmatism. But you could have a lot of higher order aberration due to some irregularity or something like that. And that's giving you a lot of problem for driving, especially when you're driving at night. I know some people who put the vehicle on the side because the headlight is too big for them. There's too much of glare. And then after a while, they start driving again. And the 10% would be intraocular. I used to do a lot of phakic IOLs, like ICL, IPCL, but now I've just cut down on these. I like more of refractive lens exchange on the elder patients because the intraocular lenses that we have nowadays are such high-end, toric trifocals and all that, and the quality of the intraocular lenses is so good. So out of 45, I usually like to go for refractive lens exchange. So what are the available options now? This is something very important. People will come to you and say, okay, I've decided to do refractive surgery. So go to Dr. Kiran. Dr. Kiran is a retina specialist, and our cousin might come and say, I'm going to do refractive surgery, tell me. And he's so confused, he doesn't know what to tell. He'll look into the internet, he'll find Contura, Vision, Transepithelial, PRK, LASIK, Smile, Silk, so many things will pop out. LASIK, EpiLASIK, so many things will pop out. The surgeon is also confused, the patient is also confused, they don't know, someone is talking, this is the best, this is the best, this is the best. There's so many laser companies. So every laser company, there are basically only two lasers. Only two lasers. One is the excimer laser, which is the gold standard for treating everything. It can do LASIK, it can treat your scars with PRK, it can treat your high order aberrations, it can treat your low order aberrations, do corneal topography guided treatments to reduce all your high order aberrations. And then you have your femtosecond laser for the lenticular extraction. The femtosecond laser also has evolved from Zeiss doing Smile, and then you have Schwind doing the Atos Smart Sight, and then Clear is from Zimmer, and Silk is from Johnson. Okay, so they all have different names, but they're all lenticular extractions. Lenticular extractions are still on the way up. If you look into the internet, it says smile, 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 smile. Everybody, I want to do Smile. But actually, they are not customized treatment. It's just your low order aberrations. So excimer laser is still the gold standard to treat your high order aberrations. So basic concept, what are we doing is we are making your cornea thin and flat, regular in the center for myopic patients. You're just making it thin. In hyperopic, you're making it steep, and some axis treatment in cases of astigmatism and smoothing in your scars. So there are certain things that we would, so for example, this is just a keratoconic patient who had, nowadays it's so easy, you can tell what a patient can see. That's the vision lag, and this is the point spread scatter. And this is a patient where we just treated. All he did is, we did a cross-linking with a PTK with a high order aberration management. All we had to do that, and this patient's vision was so much better. So you can also treat that. So there are contraindications. We don't treat, that depends from clinic, country to country. There are clinics, in our clinic we don't treat any patients below 18 years because so many things are yet to come. And even in 18 years, we don't treat high myopia, high prescriptions. So if the patient has more than -5, I usually like to wait till the age of 25. That's the right age. But low myopia, like -3, 4, you can treat, because most of our patients are also going into the army. So by 25, the army age is lost. So other things are ectasia, formfrust you don't want to treat. Formfrust is subclinical keratoconus. Active infections. So there was always a problem with viral keratitis with the excimer laser. You can reactivate viral keratitis, but with femtosecond lasers, you're much safer. Endothelial dystrophies, I hadn't added that till yesterday because I had a patient with an endothelial dystrophy, and then flap takes longer time to attach. But I think the best is, like, you don't like something about this patient, it's better not to do. Sometimes you don't know. and you have a gut feeling saying there's something not right about this patient. Even when you're doing a cataract surgery, a gut feeling that should come in, that something is not, you've seen so many normal patients and something is not right. I think year before last year, I was in an eye camp in Kavre, and then we were doing this cataracts. So I had already done about 70, 75 cataracts. And there was this man, the block was already given, and then I was about to start, and then something made me feel something is not right about this patient. And I stopped. I told the patient, I need to examine more. Let's not do surgery. So sometimes you should be able to say that. Even when everything looks normal, something is not right. After my whole camp, I came back to Kathmandu. Next morning, one of the ophthalmic assistants called me. The patient we cancelled died. He was dead in the morning. It was such a, the gut feeling. If I had operated on that patient, disaster. So there are certain things that you really want to know who are better candidates. The better candidates are younger patients. They can accommodate very well. Treatment date, in the sense, everybody wants a more experienced surgeon. The more experienced the surgeon is, to a certain extent, does make a little difference. After 100 surgeries, it's all the same. Minification effect is like, yes, high myopia, they get minification effect with the glasses. So everything is minified. So when you remove the glasses after surgery, everything is magnified. So you tend to gain more lines. So we think it is better. It's not actually, but the accommodation reflects younger patients, even older patients who can accommodate very well, they're good candidates. Keratometry, flat corneas are good. Steeper corneas are not very good because you tend to deform the cornea more because of the pressure with the treatment packs. Epithelium, like smooth epithelium, is very important, like scars or anything like that. And the results, just want to show you one or two graphs, just don't want to bore you actually. These are just results of Smart Sight. Basic results are always great, but Smart Sight, just want to show you now, 42% of the patients at 2016 day 1. 10 years down, when we started doing the clinical trial for SMILE in myopia, the best corrected visual acuity would be 2040 day 1, best corrected. And now the lenticular extractions have gone to a point where they're 2016 day 1, 42% of our patients. So it's getting better and better and better and better. I always talk about something called as refractive index change. I don't know, sometimes I give in interviews something called, you can change the refractive index of the cornea. So this is somewhere where you don't have to make the cornea thin, where you don't have to change the curvature of the cornea. And I always tell my patients that you're not fit for surgery, but when the refractive index change comes, which I thought would never happen in my life, has started from last year onwards. In Germany, there's a big time clinical trial going on, and hopefully we can do refractive index change by another 2 years. So the take-home message is smaller prescriptions do better, I feel, more than the larger prescriptions. The smaller ones, the smaller myopias, hyperopias, do better because you're changing less of curvatures. Younger patients do better. Even the older patients, like, what for presbyopia, you can always treat presbyopia. And different lasers have different names. Do not get confused. Some call it Presbyon, someone call it Presbymax, someone call it something else. When you look into your internet, everything you get is like different names. And I would just like to conclude over there. I hope you go and get a scan of your cornea done now to see how much of... very funny is, like, I was giving a similar talk like this, and there is a final year resident. Her name is Dichen. I don't know if she's around. So she was in Birtamur for a peripheral posting last week. And I was just teasing her thesis on keratoconus. And my thesis was on vein occlusion. My professor used to keep telling me, whatever thesis you've done, that's what you're going to get in the end. There's something very weird, like, So the guy who's done, so I've done on vein occlusion. So I always think in the back of my head that I'm going to get vein occlusion one day. So Dishan, I was just teasing her, we'd probably get keratoconus in future because her thesis was keratoconus and she presented also. And it's very, very weird. She's from the Tibetan community. You'll never get keratoconus. It's more in the Brahmin community where you get keratoconus. And we did a scan on Dishan, and Dishan had keratoconus. Can you imagine she has subclinical keratoconus, like big time back elevation. So friends, you should look into your thesis and see what you've done. Okay, that's what you're going to get in future. Thank you so much.
Let's take a moment to express our sincere gratitude to Dr. Kishore Raj Pradhan for an incredibly insightful presentation. He not only brought depth and clarity to the complexities of refractive surgery, but also left us with much to contemplate. We are grateful for the time and effort you invested in sharing your expertise with us today. Now, I would like to call on stage Associate Professor Dr. Kiran Sake. Dr. Sake is a cataract and vitreoretinal surgeon at Nepal Eye Hospital. He served as an elective executive member of the Nepal Ophthalmic Society. He currently holds an executive position in the Nepal Vitreoretina Society, and today he will be presenting on the topic Easy Technique for 3-piece Scleral Fixation IOL.
Thank you, Dr. Prasansa. Okay, good afternoon. I have a short presentation. I would like to thank the Organizing Committee, especially Dr. Ruchi, for giving me the space for these presentations. Today I'm going to talk about the easy technique for the 3-piece scleral fixation IOL. As you know, the scleral fixation is the procedure to implant the posterior chamber IOL in sulcus in absence of the lens capsule, and it is the first described by the Melbourne in 1986. So the main indication is the aphakia. We all know if there is a pre-existing jonular deficit in case of the congenital, just like Marfan syndrome, shoot exposure syndrome, and because of the trauma. And the most important complications after the cataract is the intraoperative posterior capsule tear. So this is one of the common indication for scleral fixation. So you know that there are the types of the secondary IOL, antechamber IOL, iris claw IOL, and the scleral fixation IOL, which includes the suture, non-suture, sutureless. So why do we prefer the scleral fixation IOL? Because the ACIOL, okay, Dr. Sanjay Singh, I mentioned that there is chances of the bullous keratopathy, and the iris claw lens they need a skill and hinders the pupil dilatation. So scleral fixation, it positions the IOL closely approximates the normal anatomical position of the within the bag IOL and has a good cosmetic. So we should avoid the scleral fixation in the following condition: the extensive limbal scarring, scleral thinning, column or choroid, microophthalmos, pre-existing filtering bleb, retinal detachment. And these are some of the types of the suture scleral fixation IOL. And in 1991, Lewis has described the purpose of the ab externo. So nowadays, the sutureless scleral fixation IOL, the eminent technique is quite popular among the youngsters. But I found something difficult with this technique. The most difficult things is that the most intraocular maneuver is the lashing the trailing haptic, okay, and we can make sure that there should be a interscleral tunnel of the 2 to 2.5 millimeter. So So I choose in between the suture and the sutureless. So I name it as the easy technique for the 3-piece skull fixation IOL, and I require only 3-piece IOL and the 80 bicycle suture. So these are my steps. The vitreous pressure or AC maintainer is kept in order to prevent the hypotony. The the cornice scleral tunnel is made to insert the IOL. The small full thickness sclerotomy 2 millimeter away from the limbus are created by the MBR knife in 1 degree apart at the nasal and the temporal side. The 3-piece IOL haptic ends are framed with the heat, and each end is docked with a single knot 3 millimeter length 8 of bicycle suture. The suture ends are first externalized with a 25 gauge forceps handsack technique, nasally and temporally, and then the haptic end externalized by pulling the suture. The IOL is placed behind the IOL, and nasal and the temporal wound is closed to a vehicle with a single suture. And the 2 millimeter intrascleral tunnel are made along on one side of the externalized haptic with a tip of the 25 gauge needle, and each haptic end is inserted into the tunnel. So I want to show my videos how I did this procedure. Video on. So this is the case of the pseudophakiac with zonular dehiscence because of trauma. Now making the sclerocorneal tunnel to remove the this subluxated IOL. Now I find the haptic end with a hit. Then I suture with a etobical 2 haptic ends, and with a handsack technique I externalize the haptic, externalize the suture, and along with the haptic end, and then the haptic end is inserted into the 2 millimeter scleral tunnel. Okay, this is the end of the surgery. So this is the picture before and after surgery. You can see the IOL in a good place, and here you see the haptic in the intrascleral 2 millimeter in the tunnel. So I did the 11 eyes of the 11 patient. We underwent the sutureless SFIL, and the mean age was 61 years, and there's no post-operative complications. So this is my final pre-operative and post-operative base corrected visual acuity. The pre-operative visual acuity is 1.33, and the post-operative visual acuity is 0.227. It is statistically significant. Okay, thank you for your kind attention.
Thank you, Dr. Kiran Sake. Now the last presentation of the day is from Dr. Tejo Singh Molla. Dr. Molla is a consultant ophthalmologist at Drishti Eye Hospital and medical director of Tej Eye Care Center. He holds central executive roles in Nepal Medical Association and serves as the treasurer at Nepalese Ophthalmic Society. He is the founder treasurer at Young Ophthalmologists Nepal and is a founder member of Young Doctors Association. On behalf of Young Ophthalmologists Nepal, he will present on the topic Youth Leadership representing the YO session. Welcome, Dr. Molla.
Thank you, Dr. Sanket. First thing first, in youth leadership. So, why youth leadership is important? So, in our medical education, leadership development is a most neglected subject. And after graduation, at times we find ourselves in situation where we are required to lead an institution, but despite our good medical knowledge, we fail. We lack the knowledge of administrative and management, law and policy, public speaking and media, communication and conflict resolution, which is essential component of good management and leadership. Youth represents the energy and hope of a nation. If the youth can be given the right values and direction, a nation can be transformed. So leadership development is important for overall success of an organization and is essential for vision, guidance, and motivation. But before that, you need to lead yourself, then lead others, and lead an organization. There are lots of leadership qualities one should have. These are all the ideal leadership qualities. Out of them, time management, trust, empathy, just service, and unity are essential. And also my name comes from that. So Tetsu. So you can always take all the criteria or ideas from here. So there are lots of important leadership skills. So today I'll be dealing with first or time management. During the time management, we have always heard many people of saying, I don't have time, I can't attend meetings. You have 24 hours just like everyone's, and it all depends upon your priorities. So what are your priorities? Even today, maybe some people are very busy and they have left early, right? But the program, we all know that the program ends at 5 or 6 o'clock. So achievers think in terms of seconds and minutes, whereas non-doers do it in days and months. Time management is the process of organizing and planning how to divide your time between specific activities and priorities. The benefits of time management include better habits and greater opportunities, productivity, increased focus, build confidence, and allows you to plan your time more effectively, improves work-life balance, and increase happiness. There are some obstacles during time management, such as unclear objectives and priorities, personal disorganization, lack of planning, distraction and interruptions such as telephone calls, emails, and guests, and inability to say no. So, other obstacles are procrastination and indecisiveness. The action delaying and postponing something is called procrastination. And personal commitment, personal obligation, being involved in too many things at once, and stress and fatigue. So, what are the strategies for a good time management? So, always set an objective. Establish objectives such as you do it in a smart way. Smart means specific, measurable, achievable, realistic, and time bound. And always prioritize. Determine which tasks you can do yourself, which you can delegate to your coordinates, and delay some to another time. And find a way to stay organized. Use a planner, calendar, notebook, or keep track of your tasks, project deadlines, and appointments. And learn to say no. Realize that you cannot do everything yourself. And when you are burdened, you have to just say, no, I can't do it. My schedules are packed, I can't come. So use your waiting time. Accomplish small tasks like reading your emails or writing your emails when you are waiting for someone, so that you will always feel that you have not wasted your time waiting for that person, but have utilized because of the other person's delay. And concentrate on one thing and celebrate success. So there are lots of tools for time management. to-do list, Partero principle, 3-21-0 rule, learn to say no, Eisenhower matrix, and time audit. So we all use this to do the list. So sometimes we are overwhelmed by the amount of work we have to do. So to have a proper planner is very essential, and a proper to-do list is essential, and most important things you keep it at the top, while the list you keep it at the bottom. Pareto principle, according to this principle, he was an Italian economics which formulated this principle, and it's a rule of 80-20. 20% of the things you do at a time can achieve 80% of the result. And like even in any meetings you attend, 80% of the decision is already done within 20% of the times. And it is vice versa, such as you wear only 20% of your clothes 80% of the time. So this principle is very suitable for business, wealth distribution, personal finance, and spending habits. Rule 3-21-0 rule. Now, according to this rule, what you need to do is check your inbox or email 3 times a day, so that all the notification and alerts you have to turn it off, and you spend not more than 21 minutes managing your inbox across 3 sessions, and in time you will need to clear it down to 0. So very often we don't check our emails, and even the emails we delay it for 1 week. 1 week is a lot of time. So you need to check it every day, at least 3 times a day, and learn when to say no. And Eisenhower matrix. It is a method used to organize duties and tasks in order to figure out priorities. And this method was used by US President Dwight Eisenhower. And it has 4 categories. What is important is seldom urgent, and what is urgent is seldom important. And you can see that there are 4 criteria: urgent, important, not urgent, important, urgent, not important, and not urgent, not important. So the urgent and important thing, you do it immediately, whereas the not urgent and important things you can plan. Urgent and not important things you delegate, and not urgent and not important things you eliminate. So we have all heard of the financial audit. We do it every year. So it's time for a time audit as well. So what you do in a time audit is you keep track of the things you do over a period of several days. This will help to get a better idea of how you are spending your time, analyze it versus how you want to spend your time. You will be able to identify the type of activities which takes most of your time, and you can identify opportunities where you can be more efficient and increase your productivity. Chunk, block, and tackle. So when there is a task, you break large project into small projects, and you complete it in less than 15 minutes. Whereas block, you set a certain amount of time where you can come back later on, and you tackle the specific tasks, focus only on the tasks rather than the project as a whole. And this is the rule of life. So in a jar, if you put sand first, you can't accommodate rocks or pebbles. So you need to accommodate first rocks, then sands, and pebbles. So rocks are big important tasks. Small and important tasks are sands, and pebbles are tasks with average importance. And in time management, what you should do is like 6% free time, you set it for yourself, 19% for family time, personal time 16%, work and duties 29%, and sleep and rest for 30%. So So the take-home message is until we can manage time, we can manage nothing else. So thank you for today's session. And thank you, Dr. Ruchi and team, for having a non-academic session. And we should have more non-academic session as well. Thank you.
Thank you, Dr. Tetsu, for the wonderful talk. To extend our heartfelt thanks, we have token of love to present to our speakers. I would kindly request Dr. Christopher Teng to present token of love to Dr. Indira Paudel. Thank you, Dr. Christopher Teng. Thank you, Indira ma'am. Now I request Dr. Sanjay Kedar to present token of love to Dr. Kishore Raj Pradhan. Thank you, Dr. Sanjay Kedar. Thank you, Kishore sir. Now I would like to request Dr. Ronald Gentili to present token of love to Dr. Kiran Sake. Thank you, Dr. Ronald Gentili. Thank you, Dr. Kiran Sake. Now I request Dr. Omar Osgur to present a token of love to Dr. Tetsu Singh Malla. Thank you, Dr. Omar Osgur, and thank you, Dr. Tetsu Singh Malla. And now I would like to request all the speakers to be on the stage for a group photo. I would like to request Scott sir to join the group photo. For sharing your expertise. To our sponsors, thank you for your support. Our sponsors, Vaishno Medicals, Shreyasi Enterprises, Sun Pharmaceuticals, Microlab, National, NPL, DCI, Centaur, Sudrishti Enterprises, Square, Roto. Thank you all for your support. And to all attendees, thank you for your active participation. Now, and finally, now we are excited to introduce a delightful and eagerly awaited segment, the Lucky Draw Session. We have an array of fantastic gifts waiting to find their lucky participants, lucky recipients. To add a touch of charm and excitement to this session, I am delighted to invite Dr. Kishore Raj Pradhan. Dr. Kishore Raj Pradhan will guide us through the lucky draw, making it an engaging and enjoyable experience for everyone. So without further delay, let's welcome Dr. Kishore Raj Pradhan to the stage and get ready for a thrilling lucky draw session. Who knows you? Who knows, you might just be one of our lucky winners. To ensure an impartial process, I want to clarify that our dedicated organizers have gracefully abstained from participating in the lucky draw. This will increase your chances to win. Best of luck to all.
Please come forward. Maybe you come closer, you get a lucky draw, be a winner, something. Or like you might miss your name, like Bolon Lapani. You might not hear your name. Please come forward. So, the only reason that we do a lucky draw or we try to give you gifts now is the reason is to promote some of these scientific sessions so that you come and listen, and we also have a lot of respect for our guests who come, and it would be very, very weird if our guests come all the way from the US and we have no attendees. So it is very important that we also understand what our foreign speakers have to say, because many of us, we have not been abroad to listen to or see some of the scientific sessions, and they're so great, so scientific. And nowadays, we are trying to give more and more prizes to the best papers. We thought we would do that. So if you give prizes to the best papers, there would be more effort, it would be more scientific, and things would be better. But now, I don't know why you called me here. So we're going to start with I think there are 5 prizes, is it? So let's start with the 5th prize. Oh, sorry, there are 10 prizes. So it looks like, and by the way, if the person is not here, that person doesn't get it. So whoever is here will get it. Just joking, no? It's like that, is it? So if the person is not here, please do come forward. If the person is not here in the room, the person usually doesn't get the prize. It's usually the lucky draw is for the person who stays back till the last. So I'm sure 10 money, I think most of you will get something out of it. So we start with the 10th prize is for rupees, how much? Oh, it's a gift hamper. So there are 5 gift hampers and there are 5 cash prizes. So I can ask, I think the 10th prize, we can ask, Chris, can you come and just pull out a paper over there and we can read out a name over there? Quiet, listen to your names. I was quiet, listening to it. The 10th prize is David Chanton. Thank you, Chris. Chris, you'll also be giving the prize to... So David you're from Cambodia, is it? So David is from Cambodia. Congratulations, David. Go for the 9th now. I can call upon somebody on stage. Dr. Sanjay, can you come and pull out a paper? So, this is Pragati Gautam. But I don't know if she's here or not. So this paper goes wasted. Is Pragati here? So Pragati is not here, so you'll have to pull out another paper for the 9th prize.
Dr. Srijana Karmacharya.
So Dr. Srijana Karmacharya, congratulations once again. There goes the 9th prize. I'm going to call upon Donald. Donald, Dr. Ronald. So I'm going to call on Dr. Ronald to pick out the chit for the 8th prize. Prize number 8, right? You leave it at- Guys, you're going to miss your name. Come forward, I think. Please come forward. सबैले पाउँछ क्या यति कति कम्ती रहेछ मैले पनि मेरो नाम राखेछ Can you imagine?
I need my glasses. Hair glasses.
Yeah.
Susan Ariga. Congratulations.
So Sujan's left, I think.
Once again, absence.
This is
Oh, he's not absent.
Sushant Adigya. Oh, Sushant's left, I think. So
it's-
Sushant had left last time also. He got out no one. But this time he's not very lucky. So there goes Sushant.
So he's disqualified.
Yeah.
Okay, let's do another one. Mrs. Resta. Is it?
Nisha Shrestha.
All right. Maybe I shouldn't be picking from the bottom. I'm
So
going to take
is
this one on
Nisha
the top.
Shrestha here? No. She's not here.
All right. Has Ronan Rasbode. Congratulations.
This is the 8th prize. Now for the 7th prize, I would like to call upon Dr. Omar. Can you come and just pull out a chit? We'll let the guests do the.
So, Dr. Professor Sarjun Joshi.
So he's left. Too bad. We'll try one more
He
time.
doesn't get it. Dr. Shraddha Tiwari.
It's okay. So this is what I said. You'll definitely get a prize.
Dr. Madhu Thapa.
Dr. Madhu Thapa is also left. Take it, sir. She was telling me, on the way, before she left, Kishore, I think I'll get a present. Keep it for me. That's what she said, the last thing she said before she left. But the sad thing is,
Dr. Uday Chandra.
Doctor, so there goes the 7th prize, Dr. Uday Chandra. Congratulations, Dr. Uday. I hope people are not having coffee outside and they miss their names. So now we go into the cash prizes now. Hey, sorry, the 6th prize is still there. So for the 6th prize, I would like to call on Scott. Can you come and do the picking part?
Dr. Adenum.
From Ghana. Dr. Edinam, are you from Ghana? Are you? Yeah, there goes the prize to Ghana. She's a fellow at Tilganga. Congratulations. So now we have the cash prizes. We start the 5th and the 4th cash prizes are rupees 5,000 each. For the 5th prize, let's call somebody from the group itself now. Since I guess we've done, I think we can start calling. Can I call upon Dr. Anu? I'm so glad to have Dr. Anu here. She's a great singer, actually, you know. I don't know if I should request her to sing also. Really?
The lucky one is Dr. Ravindra Shah.
Yay! Congratulations, Dr. Ravindra. He works in Zimbabwe, and he's lucky for he made it for the 5th prize. He was here 3 days back. Let's call upon Dr. Indira to pull out for the 4th prize.
So actually the last 3 prizes were glaucoma people. So let's see.
She's got high hopes.
Should be me now.
Every day is not Sunday.
Dr. Angira Shrestha.
She's here. I saw her.
Where is he? Oh, good.
Congratulations, Dr. Angira.
Yeah. She's also near to glaucoma because she sends a lot of patients from uveitis. So I'm happy she got it.
So then we have the 3rd prize for rupees 10,000, and I would like to call our hospital main management person, Madhuji. Can you come and please? हाम्रो हिरामणि सरकार हुनुहुन्छ. Oh.
The lucky one is Dr. Krishna Devi Shrestha.
She's not here.
Absent.
She's very, very unlucky, in fact. She really missed it.
The other lucky one is Rameswar Kumar Saha.
He's gone. He's another unlucky one.
The lucky one is Dr. Amir Achoma.
Hey! He's from Ethiopia, and he's also a fellow in Tilganga. Congratulations, Amir. So for the second prize now is for 15,000 rupees. I would like to call one of our most hardworking persons, Mr. Hiramani sir, for picking up the chit over here.
So the third prize goes to second prize, sorry, goes to Dr. Emmanuel Agnuela.
So Emmanuel is from South Sudan. He's wearing a lucky cap, you know that? He's wearing a lucky cap. Congratulations, Emmanuel. And for the first prize, the Matrika prize, I would like to call upon Dr. Chatraj Prant. I know everybody knows him.
And I think I should add to this, he's I think a little bit shy to say it. The first prize is cash prize 25,000 and it's sponsored by his hospital, Matrika Eye Center.
I hope it's not my name. I did put my name. Let me announce it. Presbyopia is really killing me. Whoever's written this is Shiva Upadhyay, Dr. Shiva Upadhyay. Shiva, oh God. You really missed out. Just please find out if she's having coffee or something. Shiva is a boy, no? No, all right. Really sorry, Shiva. Dr. Archana Budathoki. Congratulations, Dr. Archana. She's a cornea fellow. She's a cornea fellow at Tilganga. Tilganga has in fact taken a lot of prizes. The fellow programs, the fellows have taken a lot of prizes. Congratulations once again. And there's another award by a micro lab. There's 5 prizes. So I think I should sideline myself now. Congratulations to all the winners. And I don't know what to say to the ones who lost the prizes.
So thank you, Dr. Kishore Raj Pradhan, the dynamic host for the lucky draw session. Let's give him a round of applause. Now, there are 5 more prizes from micro labs and 2 more prizes from NPL. So there are 7 more prizes to go. They will host the session themselves and they will declare the winners.
So the lucky one is Bhavana Shrestha. So the another lucky person is Daki Serpa. I didn't go on. So I think she is also unlucky. So I think the lucky one is once again David Chanthang.